Hello everybody and welcome to the second video of this case. Now I wanted to go over this exam in a greater depth just because on the first time around I really skipped over a lot of things that would have been helpful to talk about, and just so you guys understand how I'm reading the x-rays and what I'm thinking. So we can use this particular video as a point of discussion for kind of what's happening with this lady in depth and why I'm trying to fix things this way and what's my rationale. So let's get into the meat potatoes of this thing. I'll orient you anatomically here so you know what exactly these radiographs mean and what's going on. So this area right here is the right of the patient. This area all the way over here is the left of the patient. And of course, upper lower is self-explanatory. This is where the midline is. We're going to sort out that midline for y'all. This is tooth number 2. This one right here is a wisdom tooth, namely number 1. On the other side, we got a 16, and this is a 15. So those are our wisdom teeth. I do think that they should go for this particular person just because they're packing a lot of food. There's a lot of calculus. I would definitely recommend for those teeth to disappear. However, she's a little hesitant to do that. So we'll just leave that up to her, whether she wants to or not. That will be her choice. Going on, number 2, you see these areas where kind of bumps on the neck of the tooth gets appeared right there, and also on this lower tooth right here. All those, they represent calculus. So those things, they come with time when there is no professional dental cleaning done. So could she actually fix that problem herself with a little bit of floss and toothbrush? Possibly. However, in her case, because she has some gum disease, it's really difficult to get into those areas and to actually clean out. So for the record, this area here is more than just 3 millimeters under the gum, and it's extremely difficult and tricky to get there with floss. Most people really don't. Same thing here. That's very, very difficult to get there with a floss. And anytime I'll touch this with an instrument, those things would bleed like crazy. So this is what's actually keeping the gum aggravated, and if these things are not removed promptly, we will see some significant bone loss in the future. All right, going on. So this is tooth number 2, this is tooth number 3, 4, this is tooth number 5. So this is where we're actually coming into a really significant problem at this point. So you can actually see this gray area right there. Let me outline that for y'all. So you can see how this color is grayer than everything else. So we're gonna draw some hashes into here to represent the cavity right there. We can also see that this cavity is darn close to this nerve right there. So when that happens on an x-ray, I mean 80 to 90%, this is going to be a root canal. And what I usually tell patients is that, hey, I'm going to try my best to do a filling over there, but most likely we're going to have to plan for a root canal. There's a couple of these instances in this particular mouth, so this is one of those. And I predict that in this scenario, we're going to have to do a root canal, build up, and a crown. So number 5, root canal, then build up, and then crown. Going down below, we actually see that one tooth has been root canaled. So this white piece of structure right here, that is a material called gutta percha. We actually use that to put inside the nerve space for the tooth so it doesn't get reinfected. And this works excellent. There are theories saying that, hey, once you do that, you've got a dead tooth. It can be really bad for you. But in all honesty, a lot of my colleagues and myself haven't found that to be any of significant problems for people. Those teeth typically chew just fine. They're asymptomatic and people don't know about them. So I wouldn't worry about root canals just yet. In general, they seem to stay put just fine. So really the biggest thing that we can do for this tooth is crown the whole thing just to reinforce it so it doesn't fall apart. Root canal teeth, they have a tendency to fall apart at some point in the future. So I would say put a crown on that guy. Okay, this is tooth number 29. I would say we're in about the same situation as we are with tooth number 5 that needed a root canal and a crown. So tooth number 5 and also tooth number 29, we're going to put the same treatment here, quotations mark, just to say we're going to do the same thing. This tooth number 30 right here, The nerve is kind of far away, so there it is. I'm going to outline it, and you can actually see how deep that cavity is right there. It looks, and I think there's a break right here, clinically speaking. So it looks to me like we have a greater chance of actually saving the nerve of this tooth. So I wouldn't label this tooth for a root canal just yet, but we'll definitely crown it to barrel hoop it. And one of the reasons to crown this tooth, let me erase all this stuff. One of the reasons to crown this tooth is actually this huge filling on top you see. And really, once you get to a filling of the size and you have subsequent breakages, I'd rather not mess around. Let's just fix it once and forever, and that will be there for her entire life. So going on to the next x-ray, it looks like everything that we have said is just repeating on this x-ray. They look pretty much identical to me, so we can put a check mark here and move on. By the way, on this x-ray, on the first x-ray, I see a little shadow in this enamel. This shadow looks a little bit better on this enamel, so rather than thinking of what I will do to fix that tooth, once I am working on this tooth here, I will peek into this tooth directly and see whether or not we need to do any treatment right there. So once I'm there and kind of doing the meat and potatoes of the treatment, that's when I will be assessing whether or not I need to do anything. Okay, moving on to the left side. Same thing. I've got a little tiny dot right there. It is most likely a cavity, but it is confined to the enamel, so I'm not too worried about it. If I need to treat it on the day of course I will. If I don't, then I'm not going to worry about it too much. Same thing here. I've got a nerve coming in here. I've got a big cavity that's happening under the filling and another side got a big cavity. So I am pretty much certain that this will end up being a root canal. In cases like this where it's so close, and let's say it doesn't end up being a root canal, but we are really close, I would sometimes advise a patient just to do the root canal anyway, because in certain situations what happens is that the nerve dies within a year. It stays put for a little bit and then just spontaneously decides to die and cause an infection. So in certain cases, when it's close enough, even when the thing survives, especially if I'm planning to crown this tooth anyway, which I am planning to do here because of how much tooth structure is lost, I would just do the root canal just to be safe, crown it off, and then we don't have to come back here and do anything with it. So most likely what we end up doing here with this tooth number 12, same thing, root canal, build up and crown. Quotes here. This tooth here, there is a big filling here, maybe some cavity here. I don't think it's close to the nerve. The only reason I would crown this tooth is for any aesthetic reasons. Otherwise, I think we can make do with a filling here. But if I'm going to be rescuing the smile for this lady, of course, I'm going to have to crown this tooth. That will most likely be a crown for more than one reason. So reason one, we'll reinforce this tooth, and reason two, we will crown it for aesthetic reasons. So this is actually number 13 here. Number 13 will probably build up and crown. Number 14, you can see a cavity right here. You can see a small cavity right there. I'll just fix these with a couple of plastic fillings. Easy. Okay, this is number 15 here. That seems to be okay. Of course, it needs this cleanup right there on this side and on this side here. That will all be tackled by deep cleanings, and I don't think we have to worry about anything else. Moving downstairs here, this is tooth number 18. It looks like it has been root canaled and built up in layers. So this is our layer 1. You can actually see the demarcation of composites. And what I think is between them here, that thin line in between of these composites, I think that's a layer of bonding material that they put on a second time after the initial buildup. So there was the initial buildup, then they put in a layer of bonding, and then they did a secondary buildup. Do I see that very often? No, not really. Is it wrong to do? Of course not. It's just the way these look. Okay, going on, tooth number 19 kind of looks the same way. I see that there's some kind of material there. I'm wondering if they used newer material here and then an older material here and then a newer material again. Since this treatment is coming from overseas, I'm not quite sure what the protocol over there is. Are they looking a little funny? Yeah. Do they look kind of healthy? For sure. So I think at this point it's safe not to mess with these. Best case scenario, I'll put crowns on these bad boys, and they will serve us for a lifetime. So I don't think we have to worry about those. So let's see, 18, 19. you can kind of see this area right there, or right there. It looks like a cavity, but what gives it away that it's not a cavity is actually this layer of this thin layer of kind of lighter material here, and the way it's kind of confined. You see that the cavities are sort of diffuse, almost like a moth-eaten pattern. Here, it's super clear cut, like as if somebody took a burr and punched it in there. What I think happened is when somebody was doing this cavity right there, instead of going right through the tooth, they went on the side and kind of cut that prep out there, filled it, and then put this filling right there. Why did they use two different materials? I'm not certain, but this is an older type of composite material that shows up on x-rays like this. So I don't think there's a cavity there. Of course, we'll look directly in the mouth, but for now, it looks reasonably okay. So just on the x-rays, we see that we need to do a little bit of treatment. Let's continue going to the panoramic x-ray, and we'll talk about that. We'll talk about this panoramic x-ray here and what I'm seeing. So a couple of things that we need to notice in order to orient ourselves. This is our joint on where the jaw comes in. This is the coronoid process right there. And this is the same thing, but on the left side. You can also see the nerve of the patient that is transversing through this bone right there. So this is kind of interesting that her wisdom teeth are transversing this nerve. Is that a big deal? Sometimes yes, but usually no. Very rarely teeth actually interact with a nerve. And luckily at our office, if we need to get a three-dimensional scan of these guys, we can always do that. And you know what, 9 times out of 10 we see that the nerve is either is to one side or the other of the root, and it doesn't really intersect with the root of the tooth. So even if we were to extract these wisdom teeth, chances are they're not going to be a problem. But of course, if I am going to extract them, I'm going to do my due diligence and take a three-dimensional scan of this entire arch, just so I know exactly what's happening anatomically, so I can keep the patient safe. So what I like about the panoramic, that it reveals a couple things that are not readily apparent. What it reveals is any infections up in the jaw, and the way you would spot those, you would actually see a dark bubble right around the root tip. So far, these are staying put, and even though these root canals, they haven't been done all the way to the tip, sometimes happens, they're not infected. It looks like they're staying put, and moreover, they're not symptomatic. So sometimes when I talk to patients, I tell them, listen, if there's a badly done root canal, there's kind of chronic infection here, I tell them, hey, you might want to get that fixed. But most of the time patients tell me, hey, it's not bothering me, how about we just watch it? And sure enough, I tell them that's okay. We'll just watch it, and you'll be under my care. And as soon as that thing acts up, then we'll get some antibiotics on board and get the treatment going. So that is a totally acceptable way to deal with that. So these are, again, these are the wisdom teeth. Hopefully we'll get to remove these guys. These are the teeth that we're going to root canal. Here, I'll circle them real quick. So I'm betting we're going to have 3 root canals. We're going to fill this guy right here, kind of check mark it. And then we're going to crown these bad boys here. Once something gets root canaled, a rule of thumb is we're going to crown it anyway so it doesn't fall apart. So we're going to crown these things here that are going to get root canaled or have a ginormous cavity right now, just to strengthen those things. So let's count up the potential crowns that we're gonna have here. So we need at least 7 crowns to kind of set things right and to strengthen the teeth. You may notice that I didn't include this canine in the crowning process. Typically, if we're going by the book, the anterior teeth or anything from canine to canine, even if we remove a nerve, it doesn't require to be crowned, just because there is not that chewing force that lands on the front teeth like it does on the back teeth. So back teeth, once you root canal them, just crown them. You'll save so much headache later on. Front teeth, not so much, unless of course it's really broken down. But when it's, when most of the tooth structure is present right there, I wouldn't worry about it too much. Let me show you guys what's happening in the mouth and what's happening aesthetically. I'm still working to improve on my intraoral photography taking. This one was particularly hard because her mouth is not that big and she has so many teeth. So let's start by kind of talking about these areas that are kind of stained. So sometimes patients come to my practice and they ask, well, is this a cavity, or am I supposed to be worried about this? And the answer is it depends. First of all, we have to explore the thing. You know, we have to put some instruments in there. And the way we know if that's a problem is if I get a stick or if I get some discoloration that travels underneath the enamel. If I see those signs and symptoms, then typically, yeah, I'll attempt to do a filling there and cover it up. What is considered a cavity that's discolored is right there, and you can actually see how this area is discolored under the enamel. So there's the edge of enamel right there, and you see that discoloration of caries kind of travel through the tooth a little bit this way. So as it's eating out the dentin, the enamel is getting discolored. So of course, this tooth is going to get repaired in some way. So just for reference, this tooth, this arch is photographed in the mirror, so everything's a little bit backwards, but this guy right here is number 30 now. So going on, visibly, they're not so bad. This arch, not so bad. You know, this half arch, not too bad. You can actually see the wisdom tooth right there. What I predict would happen if she keeps wearing those wisdom teeth, they will start bumping into this cheek right there, causing a sore spot. I just don't like how those teeth, wisdom teeth, are looking. And you can actually see how angry the gum is right there. Do you see this almost sort of a garland effect that happens around the teeth? This is really, really angry gum right there. And it's puffy and swollen because of that calculus and plaque. We just need to get in there and clean it all up. You actually see the same effect right here. Kind of notice how that gum wraps around, but it's so puffy and red. So once we do the cleaning, you'll see the gum go from red to pink. And gums are going to bleed way less when you touch them. Right now, as soon as I touch this with an instrument, I mean, we just get a massive hemorrhage at this point. So definitely, we're going to do a super thorough deep clean, and that will be a lot better. Okay, going on. You can see some alignment issues here that are starting to creep up into the exam. You see this tooth kind of be positioned this way and that tooth kind of positioned this way, making my drawing a little bit more exaggerated, just so you see the point. And then everything's all over the place, kind of things are turned in funny ways and angles, and it doesn't create for a flattering smile. You can also see that gum being super irritated right there. You see how big that is. Of course, that will go away with the treatment that we're about to do on these teeth. Another thing I wanted to point out to you guys is this area right here. So just again to orient ourselves, this is the left side of the patient. This is tooth number 14 here. This is tooth number 13, and we're going to the midline this way. So this would be counted number 9, number 8. This tooth opposing it is 19 and 20. Okay? So you can actually see that this tooth number 13 is in direct contact, cusp to cusp, I mean edge to edge, with tooth number 20. When we're doing occlusal analysis, we really don't want the edge-to-edge sort of movement. What ends up happening, and I'll draw this here in the empty blank space. If you have one tooth kind of like this, and another tooth from the bottom coming up, and you'll have a cusp, and then the kind of this sharp front cusp. So the cheek is this way, the tongue is this way. And if these are hitting together, pretty soon you'll get a flat spot on these guys. And the more this wears, the more the opposing teeth will extrude. So teeth are made to touch, and once they start to wear, of course they get a little shorter, but your body's programmed to actually extrude them a little bit more, and pretty soon you're going to have short stubby teeth. And it's not good for wear, it's not good for the health of the teeth, and once it wears significantly enough, you might get tooth sensitivity where dentin is. And of course, functionally this is bad, aesthetically this is bad. Ideally, the most ideal way to fix it is to get some brackets from an orthodontist and straighten these guys out. So it would be great if she could wear some ortho treatment to pull this out. However, because we're kind of on crunch time and trying to get everything perfect on a very limited time frame, we're going to actually crown this guy, and the crown will reposition this tooth into the correct space, so we don't have to worry about wearing braces for years and years. We can just kind of do it within a week or two. Going on to a little bit of smile analysis. So as we were saying before, you can see how the teeth are a little bit all over the place. The aesthetics of the situation are not the most flattering for this person. I also see a big gap here. We call that a diastema in dentistry. It would be nice to fix all these issues. And this is just the tooth position that we're talking about. Once you see the gums, you can actually follow the zeniths of the gum right here, and you see that they're not consistent. So it is correct that one is higher than the other, but you want them to mirror across the midline. So there's the midline. We want this one to be about as high as this one, and you see these are this one is much lower. So the zenith here and here does not match up with the zenith here and here. So you get the sloping effect when she smiles, as if her teeth are just kind of running down the hill this way. Even though it's a small effect, when we're looking like this, when she smiles, it actually has big consequences to her aesthetic presentation. So let's look at her smile directly. So you can see on her smile that even though her teeth might be on the same line vertically, like this, because of that gum issue, it looks like her smile is slanted this way. So sometimes when we're aligning teeth, not necessarily we have to align the teeth themselves, but more to the point, we have to make sure that the gum aligns correctly, so it gives us the right illusion of the smile. This is her in kind of like semi-smile. You can already see that teeth are not positioned correctly right there. And in our interview, yeah, the patient stated that she's not confident in her smile just because of how gummy it is and how much malpositioning there is happening. The occlusion here is actually pretty good. Let's talk about occlusion. So you see that the teeth are coming in correctly with no significant overbite or underbite. We would call, okay, take two on this one. The occlusion here is actually not too bad. You can see things are pretty linear as far as the bite goes. I mean, the teeth are not all over the place as far as the cusp tips are concerned. So everything seems to be more or less on the same plane. Like, we don't have to make drastic alterations to this occlusal scheme. So we're not going to try and do heroics right there. Of course, there's wear. I wonder why that wear is happening, because I'm seeing the same wear pattern on the bottom tooth. Like, check this out. There is this ground spot here and here, and I'm wondering why that is. Does she keep biting on a fork or a pen nib? Like, is there a habit there that we haven't asked her about? I'm kind of curious why that is. This is highly unusual wear pattern. So maybe next time I see her, I'll ask that question. Okay, going on to the profile pictures, we can actually see where her midline is. All right, let me draw in the midline. You can actually see that her teeth are not very far off the midline. So this is how her midline is playing between this chin button and the top of her face. It looks like we're about similar distance from the center. It looks like her nose might have been broken once upon a time. Ideally, what she would do to fix this is to go to a plastic surgeon and get that fixed. Fortunately, I can't provide those services. I'm just a humble dentist. So we'll just stick to teeth at this point. What we're going to do in order to tackle this smile, we're actually going to recrown all the front teeth that we can see in the smile. So this guy, this guy, this guy. I'm just going to write out the teeth numbers. Back to our panoramic x-ray. So everything that would be getting crowned is this tooth, this tooth. This is tooth number 5 for the record. That's getting crowned because of the big cavity and the potential root canal that we're going to do. This is tooth number 6. This guy's getting crowned. This guy, this guy. I'm also going to crown this number 13 because of that positioning issue that we discussed earlier, where it's biting edge to edge. Now let's actually go down there and see if this is the correct tooth. Yes, you can actually see this tooth number 13 right there. That's biting in a funny way against number 20. So we will fix that by giving that tooth a crown. And also that fixes our issue of a big filling right there. So just by crowning this guy, we are tackling two problems, which is the positioning issue and also the issue of having so much composite on this tooth that we might have a fracture down the road. So two birds with one stone. Also, we're gonna crown these two guys and these three guys. So all in all, we're looking for 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 crowns. And that's apart from deep cleaning, fillings, root canals, maybe a little bit of surgery. And then we'll crown everything up, make sure that aesthetics are nice. And once I'm doing the aesthetic part, I'll let you guys see on how we approach that, just to account for what the patient wants and what I think is pretty, and we'll get that project finished up. So this is our plan so far to tackle what I see, and I think we're going to have a pretty interesting case with an amazing result. All right, let me know what you guys think. Let me know if you think I missed anything. If there's any other questions, just drop them in the comments below, and I'll try and answer them in the next video. All right, cheers.